that you need a longer dose, short-term benefit is there, another term they are coined that is a high risk. With this 2017 AHA guideline has, the benefit is usually moderate in all situations. And subsequently, what is that? Multiple publication in 2023, there was a publication showed that when given in acute phase of cause, corticosteroid appeared to reduce the risk, reduce inflammatory short-term benefit is there. Multicenter prospective, Japanese prednisolone therapy are an effect similar to those in race. So then thereafter coming out that the in high risk group, there is a beneficial effect of corticosteroid. So in 2017, the AHA recommendation for adjunctive therapy in primary treatment, so the single dose clearly said methylprednisolone should not be administered with IVIG as routine primary therapy for patients with KD, and may be considered administered longer course corticosteroid may be considered in high risk patient. This may has disappeared in 2024 HA guideline. Intensification, so they have now counted as a high risk patient who are high risk, baseline coronary G score greater than 2.5, infants less than 6 months, and high risk category using SON risk category where age, G score, Asian origin and CRP are the pointers, whether more than 3 they are according to them, it belongs to a high risk group. So high risk means this group. 18% of infants less than 6 months, their G score increases by 8 weeks, within 8 weeks of diagnosis, even despite of timely treatment with IVIG, and infants of 6 months have 5 times risk, on the first 10 than 5 times more likely to develop G score, more than 2.5 than in children more than 6 months of old. So children with less than 6 months are at high risk, greater than 2.5 is at high risk, and the SON score, the high risk SON score is there, then they are considered as a high risk. So this group needs an intensification of therapy. That now this is the AHA current guideline where they have the intensification, their position, current position of corticosteroid is in the intensification of therapy. And 2 forms of corticosteroid can be used, is prednisolone and methylprednisolone. Corticosteroid is, according to race, it is given 2 milligram in both situations, 2 milligram per kg per day. It is there, it is every 8 hours, according to race study, and every 12 hours. In both situations, maximum dose 60 milligram, 5-day course, and still it remains, people subsides another hospital, then per like 2 milligram per kg every 8 hours, slow tapering for about 15 days, maximum 30 days, once CRP is normalized, and the reduction is 5 by the half every 5th day. So this is the current recommendation, and the current recommendation is that means it should be used in high risk children. It is as its position currently is intensification. Both prednisolone and methylprednisolone can be used as IV. In our country is IV methylprednisolone easily available and cheap. So we have to adopt this to the best of my knowledge, and that can be, and you have to use the corticosteroid for a longer period of time. So other intensification agent is infliximab and etanercept we are using, we have discussed in detail in the last 2-3 days. So points to be kept in mind, the caution that data is from randomized control trials are lacking. Many of the studies are retrospective in nature and small numbers. This study must be interpreted with caution. Still, the Dr. Tomoaki Kawasaki said on the day 1 that needs to be interpreted with caution. Still, it is there. And prospectively randomized study with uniformity in dose, nature of drug, G score, and absolute value is required. So take home, corticosteroid is a safe drug in acute KD. Confirmed short-term benefit seen in all studies. High risk should receive as it a primary intensification therapy. Single dose is not calprotective. A prolonged course of only calprotective. With this, I would like to thank you all for presenting.
Thank you, Dr. Tapas, for the comprehensive review of a very contentious topic. So, questions.
questions for Dr. Tapas.
is the practice in various centers across the country? Manjari?
So as Sir said that it is the most used and the most abused drug. So prior to 2016, we were also not using steroids and we were scared of the steroids, but we were using them in Kawasaki shock syndrome and in Kawasaki associated with active activation syndrome. But post race trial and we did a little study and looked at our own retrospective data and tried to see which children were resistant, and then we started using steroid as soon as we, if it's an infant and has a coronary artery score of Z score of 2 or more, we upfront intensify now.
Since how long you are using?
From 2017. So we are now using this from 2017 onwards.
Is that your first drug?
No, sir. Of course, after IVIG.
No, after IVIG, the first drug that you use is steroid.
2 milligram per kg.
So you prefer that to infliximab?
Yes, sir. 2 milligram per kg, and initially we were using infliximab. Initially, pre-2017 we were doing this. We were using IVIG, then infliximab, then second dose or a second dose of IVIG, and then infliximab. But post 2017, we are 17 and onwards. We are using IVIG, intensifying upfront with 2 milligram per kg, methylprednisolone in 4 divided doses or 3 divided doses intravenously for the first 3 days at least. Once the child is afebrile, then we switch to oral prednisolone in 3 to 4 divided doses, again 2 milligram per kg of prednisolone equivalent, and then once the CRP is negative, then we start tapering like how the race trial tapers rapidly from 2 to 1.5 to 1 to 0.5.
Continue for how many days?
For about 3 to 5 days each taper, so about 3 weeks or so. And in some children we are required to give steroids a little longer time, and in some children we are required to give other drugs like infliximab also, or cyclosporin also, and we've fallen back on you for all of those difficult cases now. We've not used anakinra in any of our patients so far.
What is the experience of South India?
For the last 4 years, we are giving steroids like acute therapy. But we give it 2 mg per kg IV methylprednisolone till the CRP normalizes and child becomes afebrile. At discharge, we give oral prednisolone, OD dose of 4 to 6 weeks. Till that,
Before 2017?
No, you would use it in selected patients?
yeah, only on selected patients, like infants who have aneurysms and diagnosis, we give IV steroids. The same infants and who is having aneurysms, who presents late, beyond 10 days, we give IV methylpred pulse, 30 mg per kg per day for 3 days, followed by oral steroids.
Suppose a child with Kawasaki disease is not admitted directly under you, but in some of the other units. Are those consultants also open to using steroids, or?
So in such situations, we will take over the patient because they are hesitant to give the therapy that we tell. They are okay for IVIG. So nowadays, we insist them that if it is an infant with KD, we take over the patient directly. So normal other KD, we will tell them to give IVIG. Any additional therapy we wish to give, so they will also are ready to give the patient to our unit, so we will take over the patient.
So in case of resistance, what was your protocol?
So resistance we give infliximab. Like infants, we give 3 drugs. So resistance we give infliximab and steroids. So for the last 3-4 years with the augmentation, I think the rate of resistance have significantly dropped. In the last 3 years, I have not seen any IVIG resistant KDs. That's also, I think, true with regards to many centers. Even I spoke with Suman advance. She is also not seeing any IVIG resistance for the last 5 years.
Because you are preemptively.
Yes,
Yeah,
yes,
it's
yes. That's true also actually. And the rate of regression also, though it is not published, we see that the rate of regression of aneurysms are also a bit faster with this therapy. The only concern what I reviewed with the paper is that the development of late coronary aneurysms in the vessels which were not having aneurysm at initial diagnosis, maybe few decades later with initial use of corticosteroids. There was one paper, one of the risk factor for late coronary aneurysm is usage of steroids in the initial diagnosis. And over the last 3 years, I spoke with ma'am as well as Hamada sir also regarding their hesitation to start steroids in Japanese population. Till now, they are a bit hesitant to give steroids upfront. The reasons they are a bit hesitant only. They are not.
But the registrar is from their country.
But it's not like pulse and all they give. So yesterday also she presented their experience. So it's like they are not so okay with steroids. So the reason I don't know. Maybe late aneurysms.
Other centers, Dr. Sadiq, would you?
Which I in the assistant grade, previously we said that second dose of IVIG, but now we strongly prefer for infliximab and steroid, and not the second dose of IVIG.
Preemptively.
Yeah.
Dr. Shivpuri, Abhay,
Sir, similar, depends on the high risk or not. So I would upfront give IVIG plus protocol if there is an infant with a high. Infant definitely. If there is no other risk factor, if there is no other risk factor, I would only use IVIG in aspirin, but I use primary intensification. Also has been that the resistance is, especially as I'm working in the private setup, is a big issue. So I would steroids rather than not.
so often are you using?
At our center for prevention, we are using infliximab. If child has aneurysm, use prednisone 2 mg per kg. The CRP is negative, then we take and the factor into consideration for intensification age, child is infant, is the dilatation and coronary artery.
Center in all infants will be IVIG, and if diabetes. Recently we have said from onwards we are giving all the food we are giving. If there is diabetes.
It is your current 5 years back, what was the practice?
That
You are not there.
What Dr. Tapas has highlighted, some bit of it has percolated down in clinical practice as well. So we are now using steroids. Flavor varies. Some centers use oral, some parenteral, but now are much more liberal, and that Dr. Tapas also wanted to review. We thank you, Dr. Tapas. We presentation, and this will be by